All right, everyone, it is now 5:05, so we'll just be letting in any more participants throughout the seminar. But for now, we're just going to get started with our introduction. So we are Advocate for Lives, a youth-led organization that raises awareness for both blood and organ donation, as well as health-related research. And before we begin, we just want to go over some few housekeeping rules, such as please don't spam the chat and keep any messages in the chat relevant to the seminar. As well, please don't use any inappropriate language such as swearing or anything like that. And have your mics muted just so that we can have this presentation without any interruptions. As well, you probably already got the notification that this seminar will be recorded. And we just do that to post it on our YouTube channel for anyone who wants to come back and listen to these presentations. Finally, if anyone would like to get volunteer hours from this seminar, we would appreciate if you could change your name on the Zoom to your full name, just so we can have them for our certificates. And we'll explain more about how you guys can get your hours at the end.
Okay, so now that we've got that out of the way, today we're going to be talking to Dr. David, who is a current chief resident for anesthesiology and a former member of the admissions committee.
Awesome. Let me just pull up my slides here and then I'll get started.
For sure. And we'll be addressing all the questions at the end. So for now, Dr. David, you can take it away.
Awesome. Thank you guys for having me first off. My name is David Janiczek. I am a fourth year anesthesia resident at the University of Illinois, Chicago. I'm also one of the chief residents this year, finishing up my chief year in the next 3 months here. I'm also the founder and CEO of Get Admitted MD, a company to help pre-meds get into medical school. This was based on my time on the admissions committee during medical school and just helping out students along the way. And then I also created an online course to help students understand the medical school admissions process as well. So a little bit more about me. I'm originally from Iowa, born and raised. I went to the University of Iowa for undergrad and medical school. And like I already mentioned, I'm now at the University of Illinois, Chicago, finishing up my anesthesia training. And then I'll go on to fellowship next year, or actually later this year, where I will be down at Ochsner Medical Center in New Orleans. So here's what we're going to talk about today. I want to start things off with a little bit about why anesthesia, why I chose the field, why you may be attracted to the field of anesthesia. Next, I will talk about what is anesthesia. There's many different components of anesthesia. And so we'll go over 3 different cases, one involving general anesthesia, which many of you think about as probably what you see on TV and everything like that. NEURAXIAL anesthesia, that's a specific type of anesthesia we can provide. And then also the world of pain management, which is very popular these days, and it's a very needed subspecialty of anesthesia. I'll talk a little bit about the path to becoming an anesthesiologist, and then also a subfield of anesthesia called Certified Registered Nurse Anesthetists, or CRNAs. So I'll touch on that a little bit later. All right, so why did I choose anesthesia? So here are 6 reasons. So basically, the first one is I was always interested in physiology. I developed, this love for anatomy and physiology as a high schooler, actually. And so I took an anatomy and physiology course. I just fell in love with it. And just learning how the body works on a daily basis is super interesting to me. And I studied physiology in college because of this. Anesthesia takes that a step further. So basically we have to know the physiology, what's the normal physiology, what's abnormal physiology, but we also need to know the pharmacology, or basically how do we use drugs to change the physiology for the patient, during the surgery. So next, I just had a love for the operating room environment. So some people are very attracted to the operating room. Some people hate the operating room. It's kind of a love-hate relationship, but I definitely enjoyed it. I knew I wanted to do something in the operating room, but I didn't want to be a surgeon for many reasons. And so, anesthesia was kind of a perfect fit there. I am able to do procedures. So we often do, central lines, which are big IVs we place in a patient's jugular vein. We do those for transplant surgery, cardiac surgery, those types of things. Bigger operations where we may need to do, maybe need to give blood or a lot of fluid to the patient. We do epidurals, so I'll talk about epidurals a little bit later. We intubate patients, we place IVs, we do all these things with our hands. So it's, very procedural oriented field. I get to work with different specialties on a daily basis. So I can work, one day I could work in the operating room with orthopedic surgeons, the next day I'm with cardiac surgeons, the next day I'm with general surgeons. So it just brings a lot of variety to the field. And I don't need to know, insane amounts about each specialty. I just need to know enough to take care of the patient. So it does provide a nice breadth of knowledge about a lot of different fields. My interventions can have an immediate impact on the patient. So, the classic example is if I see, the patient has low blood pressure in the operating room, I can treat it with a medicine and it will go up. I never wanted to be the physician that, saw a patient in clinic, told them to come back and see me in 3 months and give them a prescription. I don't know if the patient's going to take the prescription. I don't know if it's going to work. I don't know if insurance is going to cover that drug. There's just so many factors that I didn't want to deal with. So, in the operating room, I give the patient the medicine. They get it through their IV. And, I can see the immediate response on our monitors. So it's a very, kind of immediate feedback loop. So I found that very attractive to the field. And then the last one, there is very little continuity of care. So some of you may think that that's a bad thing. I didn't necessarily want to develop those long-term relationships with patients and their families. I was okay with seeing the patient once and then potentially never seeing them again, in terms of they may never have surgery again, or surgery at the hospital that I'm working at. So anesthesia is not a great field if you want to develop long-term relationships with your patients. But sometimes this is actually a good thing. So it just depends on how you look at the subject. But that is one thing that I viewed as a positive. All right, so let's move on to, what is anesthesia? The first thing we're going to talk about is what's called general anesthesia. This is classically what you probably think about with anesthesia and surgery. So it is basically made up of 4 pillars. So analgesia is pain relief. So obviously we don't want the patients to be in pain during the surgery or immediately after surgery. Paralysis or muscle relaxation. Not every surgery needs the patient to be paralyzed, but we can use medicines to temporarily paralyze the patients. They're called neuromuscular blockers. So basically, they just basically prohibit the muscles from working. There's reasons to do this, but like I said, you don't need every patient or every surgery to be involving muscle relaxation. Amnesia is a loss of memory. So we don't want the patients to necessarily remember the surgery or going into the operating room itself. That can be a very stressful time for them. And so we give them a medicine that basically blocks their memory for a couple hours. And so they don't really remember, much about the surgery or going into the operating room itself. And lastly, unconsciousness. So basically, we want them to be asleep for the surgery. We don't want them to be awake, moving around if we're doing general anesthesia. So, obviously we give them medicines to make them unconscious. And so on the bottom of the slide, you see a spectrum here. So there's other types of, anesthesia that I just want to briefly mention. So on the far left, there's the awake state. And so there's local anesthesia, NEURAXIAL anesthesia, which I'll talk about in a little bit, and then regional anesthesia. So if you guys have ever gone to the dentist and they've numbed up, your gums or your mouth for any procedures, you've had what's called local anesthesia. So basically that's a medicine that can be injected and it numbs up a specific area of the body. If you do that to, say, an entire limb of the body, so say you're having elbow surgery, and you can actually numb up the entire arm, and that's called regional anesthesia. So that we basically search for the nerves in the neck here that supply the elbow. We can inject a little bit of medicine around those nerves, and that numbs them up, and that's called regional anesthesia. And then lastly, NEURAXIAL anesthesia, which I'll touch on a little bit. Basically, that's your epidural anesthesia that you think about when females are pregnant and going into labor. In the middle of the slide here is this, or the spectrum is this sedated state. So we can give patients medicine through typically an IV. And that will put them into this sedation state. So basically, they're not fully asleep, but they're not fully awake. So this is used for small procedures that doesn't require fully asleep patients. And so, minor procedures that, can get away with sedation, we try to do that. And then lastly, we have general anesthesia, which is all the way off of sleep. We have to place a breathing tube after you're asleep so that, we can hook you up to our ventilator for the surgery itself, because we'll give you so much medicine that you won't be really breathing on your own. So that's what you classically think about with, kind of the mask and counting back to 10, those sorts of things that's general anesthesia. So there's also another way to think about this. This is, there's 3 phases of general anesthesia. So there's a lot of parallels between the airline industry and anesthesia. So the first phase of anesthesia is called induction. This is also taking off. So this is a very tedious time. It's a very tenuous time. So you need to be very vigilant during induction of anesthesia. So this is basically when the patient's going off of sleep. The next phase is the maintenance phase, or basically when you're up on autopilot. There's small things that can happen, small changes here and there, but for the most part, everything's very smooth. And so you're kind of just cruising. And then the last phase is emergent. So this is waking a patient up. This is akin to landing a plane. So once again, very tedious, very high stress time where a lot of things can go wrong. So you need to be extra vigilant during this time as well. And just like a plane, patients don't just wake up when we turn off the anesthesia. It takes a few minutes to wake up. So you kind of have to plan it out, just like a plane approaches the runway and plans it out. So it's much slower than the actual going off to sleep phase. All right, so let's get into a case of general anesthesia. So we have a 19-year-old male. He's 75 kilograms. His BMI is 24. His history of present illness or HPI, he had sharp abdominal pain that started near the belly button 2 days ago and is now in the right lower quadrant. He endorses being nauseous and he has vomited a couple times since the pain started. And he does have a fever up to 102 degrees Fahrenheit today. Past medical history or PMH, just some childhood asthma, but he doesn't take any inhalers, doesn't really bother him anymore. Unknown surgical history, you can find that out later. His family history, his mother has type 2 diabetes, his father's got high blood pressure or hypertension, hyperlipidemia or high cholesterol and obesity. Social history-wise, he doesn't drink alcohol yet, smokes marijuana daily, and he doesn't do any other drugs that he endorses. So what other information do we want? So when we go see the patient, we confirm all that stuff that we found out through chart review, and then we ask a few other questions. So we ask, any previous anesthesia, or is this your first time having surgery? If they've had anesthesia before, then we ask, have you had any complications from the anesthesia? Obviously we want to know if they, have any adverse reactions to anesthesia. Maybe they had postoperative nausea and vomiting, which is common after anesthesia. And so we want to know that ahead of time so we can prepare for that. We can give them extra medicine to help prevent the nausea and vomiting if needed. If they have any family history of anesthetic complications. So there's a specific disease or illness called malignant hypothermia that can happen under anesthesia. It runs in families, so it doesn't happen to everyone. But typically if your family has a history of it, kind of all the family members know about it. So it can lead to a high fever after surgery, muscle rigidity, and can lead to death. So it's very important that we know about this if it runs in their family. It doesn't mean that they can't have anesthesia. We just have to take extra precautions to prevent any of those adverse effects. We always ask, do you have any allergies to medicine? We definitely want to know if they have any allergies, because we don't want to give them a medicine that they're allergic to and cause an allergic reaction under anesthesia. And so, the most common is probably, antibiotics that they're allergic to, mainly penicillin. Allergies are pretty common. And so, if they have an allergy to penicillin, we want to know so that we can give them other antibiotics for the surgery. We want to know what their last PO intake is. So basically, the last time they had anything to eat or drink. We want to, basically make sure that they don't have a full stomach when we put them off asleep. That can cause what's called aspiration. So basically, stomach contents can come up from the stomach through the esophagus, and they go back down the trachea into the lungs, causing a really nasty pneumonia. So if they just ate a steak dinner with mashed potatoes, we would prefer to delay the surgery 8 hours before, putting them off to sleep. If it's a true emergency, we just have to deal with it and hope that nothing comes up through the esophagus. And there's other precautions we could take in that instance. And then lastly, we do a quick review of systems. So we kind of go head to toe and make sure we're not missing anything. We make sure they haven't had a stroke, seizure, heart attack. They have no lung issues that are not otherwise marked in the chart, those sort of things. So we basically just go head to toe by organ system and make sure we know everything we need to about the patient before putting them off to sleep. So one thing that's very different about anesthesia from most other fields is the physical exam component. So most physicians have a very structured physical exam where they, list the heart, lungs, look at your eyes, look at your ears, those sorts of things. For the anesthesia exam, we're very focused on the airway. And so that's what keeps us up at night. That's what gives us nightmares, is difficult airways. If we can't intubate a patient, that's what scares us the most. And so, we are very focused when we see the patient on the airway. So what I have here is basically an example of what's called the Mallampati classification. So it's a way to categorize a patient's airway so that we can, have some idea of maybe they're a little bit more difficult to intubate, or maybe they're not. And so it goes from 1 to 4, 1 being the best, 4 being the worst. And so class 1, you can basically see, when the patient is, so essentially the patient is sitting up, looking at you, and they open their mouth. And so what we're looking for is, if we can see the uvula here, we can see the tonsillar pillars at the back of the oral pharynx, the tongue is right here, you can see it's coming out, and there's lots of space here. And so we can, obviously see way more structures here than class 4. And so this is associated with a little bit easier time intubating the patient. Class 4 is the opposite. So you can see the tongue takes up a lot of this image here. We don't see the uvula. We don't see the tonsillar pillars. It just looks cramped and crowded. These are patients who have very difficult airways, and it can be hard to intubate the patient. In the middle here, class 2 and class 3 are kind of in between. And so class 2 is more like class 1, class 3 is more like class 4. But basically it's just varying degrees of what you can see when you ask the patient to look at you and open their mouth. So luckily our patient has a class 1 airway. Generally young, healthy patients have class 1 airways, but it's not 100% certain. You can have, young, healthy, skinny patients with class 4 airways as well. It just depends on your anatomy. So other things we look at when we examine the patient, there's something called the thyromental distance. So we have the patient look up and basically, see how the distance is between the tip of the chin and the tip of the thyroid cartilage. We can measure that in centimeters, or we can measure it in finger breadths. It just kind of depends. And then a shorter distance here is associated with a more difficult airway to intubate, versus a longer distance is associated with a maybe easier airway. Mouth opening, obviously we want to know if the patient can open their mouth. If they're coming in for jaw surgery and they can't open their mouth due to pain, it may be kind of hard to intubate that patient. If they're able to open their mouth fully, no pain, no limitations, then it's a little bit reassuring. We do, some of the basic, exams that other physicians do. So cardiac exam, we obviously want to know what the patient's heart rate is, what their rhythm is. Is it a normal sinus rhythm, what they call it, or atrial fibrillation or other abnormal rhythms. We want to know if they have any murmurs or basically abnormal sounds in the heart when we listen to it. Respiratory wise, we want to know their lung sounds. Does it sound like they have a pneumonia brewing before we take them back to the operating room? So on and so forth. And then obviously IV access is very important to us as anesthesiologists. That's the way we give patients medicine. It's kind of our lifeline. And so if the patient's IV is not working, we usually place a new one before taking them back to the operating room. But if they have a great IV, then we can use that for the surgery. All right, so let's move on to the operating room. We've gotten the patient in, and now we're about to intubate them. So how do we intubate a patient? In the bottom center here is the most basic way we have to intubate a patient. This is called a laryngoscope. And so basically what this is a battery operated device that we use. So here's a battery pack inside here. At the end of this right here is a little light that we use to look inside the patient's mouth, which I'll show you in a minute. But basically, this is it's called a blade, but it's not sharp in any way. It just basically moves the tongue out of the way so that we can see the vocal cords and the glottic opening, which we're looking for. You can see up here in the top left corner, this is actually called a video laryngoscope or a glide scope. The glide scope is just a brand name. In general, it's just called a video laryngoscope. Anyway, essentially what they've done is they put a camera here at the end of the laryngoscope blade. It shines on a monitor that's sitting next to the patient, and you can basically see the glottic opening here. So these are the vocal cords. And so this is where the breathing tube goes when we intubate a patient. On the bottom left here, you can just see different types of blades that we have for the laryngoscope. You have curved blades here with varying sizes. So the small ones obviously are for more pediatric patients. The larger ones are for more adults. These are called Macintosh blades. These straight blades over here are called Miller blades. Honestly, you can intubate patients with both. It just depends on what you're a little bit more comfortable with. In the top right of the slide, you see what's called a McGrath laryngoscope. So it's essentially a more portable version of this video laryngoscope. So there's still a camera here at the end, but instead of this nice big screen here, you just have this little screen right here. It's advantageous if you're going to the ICU to intubate someone and you need something portable. You could put this in your pocket and carry it up to the ICU with you. It's a little harder to wheel this whole assembly up to the ICU. And then lastly, in the bottom right corner, you see, this is called a fiber optic intubation. So basically this practitioner is using a fiber optic scope. So at the end of this long black tube here, you see, basically you have a camera. And so you can guide it into the patient's mouth. There's usually a screen on the side that you can see what your, basically the end of the scope is looking at. And then you have your breathing tube right here and you slide it in once you're in the right spot. So this is actually, a picture of how someone would intubate. So this anesthesia practitioner is basically using a direct laryngoscope to move the tongue out of the way. So in this image, you can see the laryngoscope is here, the tongue is being pushed out of the way, and then the breathing tube slides in behind it and goes into the trachea. You can see really close to the trachea is the esophagus. So sometimes inadvertently the breathing tube will go in the esophagus. It's not a big issue if it happens, once we realize it and we can adjust it. So, the problem lies if it stays there unrecognized, it can cause some issues. The patient can, their oxygen saturation could go down because it's not in the right spot. Obviously, we want the breathing tube in the trachea so that the lungs can perform the gas exchange. And that's, the breathing tube is really the way that gas exchange is carried between the lungs and the anesthesia machine. So it's really important that we have the breathing tube in the right spot. So when we look in the patient's mouth using a laryngoscopy, this is what you'll see. So once again, we have a grading scale. It's a Cormack-Lehane grade is what it's called. So once again, 1 to 4, 1 is the best. So as you can see the entire glottic opening. These vocal cords are nice and prominent. You can see the space in between them. That's where the breathing tube actually goes. The epiglottis, which is up here, is pushed out of the way. And then grade 4, you basically don't see any of those structures. You just see, this is the back of the tongue with these little papillae, or basically these little bumps. This would be a very hard view to intubate a patient with. Grade 2 and grade 3 are in the middle once again. So grade 2, you can kind of see a little bit of the vocal cords right here. You can often slip a breathing tube in underneath there, underneath the epiglottis, which is this part. And then grade 3, you don't see any of those things. You just see the epiglottis blocking your path. So if you're really experienced, you can intubate with a grade 3 view, but if you have a grade 4, usually you should try to optimize the view a little bit better. And then if you can't, then there's other options for getting the breathing tube in. So luckily, once again, our patient has a grade 1 view, and we're able to get the breathing tube in safely and efficiently. So the patient's intubated. What do anesthesiologists do now? So if the case needs any additional monitors, IVs, arterial lines, central lines, anything like that, the patient, or we place those after they're intubated. So an arterial line is basically just a blood pressure monitor that it's like an IV, but it's hooked up to a pressure sensor. And it gives us the blood pressure every single second of the procedure instead of every couple minutes, which the blood pressure cuff does. If the patient needs to be positioned in a different manner than they were when they were intubated, then we can move them after they have the breathing tube and it's secured. It doesn't need to be done for every procedure, but if the surgery warrants it, then we can change their position. Basically, we continuously monitor their vital signs, so their heart rate, their blood pressure, their oxygen saturation, their temperature, all those things throughout the entire procedure. And so while the surgeon's operating, that's what we're working on. Once the surgeon's done, they usually tell us, hey, we're wrapping up, and we start the wake up process, which I said can take some time. And so we do that by turning off our inhaled anesthetic. So what that is once we place the breathing tube, the main anesthesia that most patients receive is actually through the breathing tube. It's called inhaled anesthetic. So it's basically a vapor that they breathe through the tube and is absorbed by the lungs, and that's what keeps them asleep. If we gave them any medicines to paralyze them for the surgery, we can reverse that with basically antidotes to the paralysis medicine. So we definitely want to do that before they wake up. And then we will extubate the patient, or basically remove the breathing tube and take them to the post-anesthesia care unit, or the PACU, where they'll be monitored for a little bit, and then either discharged or taken to a bedroom upstairs, a hospital room for the night. All right, so let's move on to neuraxial anesthesia, which is another type of anesthesia. So it's kind of divided into three broad categories. So a spinal, an epidural, or a combined spinal epidural. So basically a spinal is where local anesthetics, most of the time it's bupivacaine, but there's a couple other medicines we use. These medicines are very similar to what dentists use to numb up any area of your mouth. Those dentists typically use something called Novocaine. So bupivacaine is a cousin of that. And then we also typically use an opioid, so fentanyl, Dilaudid, something like that. And we inject these medicines into what's called the intrathecal space, which I'll show you here in a second. Some advantages: quick onset, typically within 30 seconds to a minute, you'll start feeling things. And then it's great for pain control for a variety of surgeries. So not just, it's used in labor and cesarean sections for pregnant individuals, but you can also use it for other surgeries. So knee replacements, hip replacements, those sorts of things you can do with a spinal. The epidural, so basically it's local anesthetic, so just like before, and plus minus opioid, injected into the epidural space, which I'll show you on a diagram here in a second. And then combined spinal epidural is basically where we just combine the two into one procedure. We do it all at the same time. And it can be great for, labor and other procedures as well. So neuraxial anesthesia in general, just to kind of set the stage, this is a cutaway of the spine and the vertebral column. So this is basically a sideways view of it. So each one of these bone-looking structures is a vertebrae. And then on the back here are the spinous processes. So if you guys have ever felt your back and felt, bony structures going all the way up, those are the spinous processes. And in most people, you can feel that. And so basically, this is your spinal cord here in the middle. And as you can see, it ends right about here. So this is usually like L1, L2, somewhere in there. So the lumbar 1 or 2 vertebrae level. And then after that point, this is going down towards your tailbone, if you will, are these nerves that are basically in this fluid, the CSF, or cerebral spinal fluid. And so basically we do epidurals and spinals, typically at a level where the spinal cord isn't even there anymore. It's already ended. It's just this kind of sack of nerves. Now we can do thoracic epidurals for certain types of surgeries where we are working, up here in the thoracic spine. But it's a little bit more rare. Most epidurals we do, especially for labor, they're all on the lumbar spine here, so kind of the lower part of the spine. But anyway, I'll start with spinal anesthesia. So basically, this is a needle that we would place in between the spinous processes. And our goal is to get into the sac of fluid, the CSF. And this is called the intrathecal space. And so what we do is basically just find 2 of the vertebrae at the level that we're interested in, and we inject a spinal needle through that. And we look for CSF to return, or basically come out the end of the needle. That lets us know we're in the right space, and then we can inject our medicine through that needle, and you would start to get pain control after that. The epidural is a little bit more complicated. So basically we need to find this space called the epidural space. And so basically it's a space that's between two layers of tissue. And so what we need to do is we use a different type of needle to do this, but the idea is the same. So we essentially try to go in between two different spinous processes of the vertebrae. And then I'll show you on the next slide, but basically we try to find this space, and then we typically leave a catheter behind. So a very, very small plastic tube that can deliver medicine continuously through it. And so if we do a combined spinal epidural, we don't do it at two different levels. We typically do it at the same level, and we just leave a catheter right here if we were doing it at that level. All right, so let's talk about a case. This is a 32-year-old female. G1 P0 just means it's the first time she's pregnant. She hasn't given birth yet, so that's the P0 part. She's at 39 and 5 weeks gestation, so she's right at the end of her labor, and she's actually, or right at the end of her pregnancy, she's actually in labor when she presents to us. Her contractions are every 4 minutes, and her pain is 9 out of 10 in severity during the contractions. The OB-GYN, or the pregnancy doctors, have checked her recently, and they said her last cervical exam shows she's dilated to 5 centimeters and the baby's at a station of -2, meaning that it's still, we have some time before the baby's coming. So the question is, what can we offer her for pain control? We could do a spinal in theory. She's still pretty early on in her labor course, so that may not be the best option, because it's a spinal is really good for the first about 90 to 180 minutes, and then it will wear off. We could do an epidural, or we could do a combined spinal epidural. So basically, depending on your practice or the hospital you're working in, is you would likely do an epidural or a combined spinal epidural. So why not a spinal? Like I said, it's really a one-time injection that we can make. It lasts for about 90 to 180 minutes, depending on which medications. You can add some things that make it last a little bit longer. But there's no way to know that the patient's going to deliver the baby in the next 90 to 180 minutes. So you may get away with it, but at the same time, you may not. And the patient may call you back saying, hey, I'm in pain, in 180 minutes. And then, your options are a little bit more limited at that point. In terms of epidural versus combined spinal epidural, or CSE, it's kind of, a debate that's outside the scope, but the basics are an epidural has a slower onset of pain control. Basically, you titrate the medicines or give them slowly until you see an effect. And then the CSE is quicker, so you still do that spinal dose of medicine that takes 30 seconds to a minute to kick in. But there's other risks. So you can have what's called hypotension or low blood pressure. You also can get what's called a post-dural puncture headache. So it's a really bad headache, kind of like a migraine after an epidural is placed. Not every woman gets it, but it is possible if you do a CSE. So those are the kind of the risk benefits you have to weigh as the anesthesia provider, and ultimately which one you choose is up to you. So here's what I was talking about, the epidural technique. So basically what we have is we have the patient sitting up. Usually we can do them if the patient's on their side, but it makes it much harder. Usually we have the patient sitting up, and we essentially use our hands to feel for these processes on the back. Once we find the right spot, we go in between two of these spinous processes. And basically what this is the needle that's attached to a syringe with saline or basically just salt water in it. And there's a little bit of a bubble here. So we want a little bit of air in the syringe because then we can get a nice bounce from it. But basically what we do is we advance this needle slowly through skin, subcutaneous tissue, and then there's ligaments. In between each spinous process, there's ligaments. And so we can kind of feel, it's all based on feel. So we kind of feel what it's like to go through the ligament, and then we know where we're at. Sometimes we miscalculate and we're actually, we hit bone, or we're going at the wrong angle. So we may have a needle, kind of hitting this bone. So then we have to redirect, all those sorts of things. Anyway, we keep tapping this syringe. Basically, as we're advancing, we tap the syringe, every couple millimeters until it becomes very easy to push the syringe in. That's called loss of resistance, this first type of way to place an epidural. And so once we find this loss of resistance, then we can leave the catheter behind. That means we're in the epidural space. The reason why there's a loss of resistance is because this epidural space basically is a potential space, so we can open it with fluid. And so potential space is essentially, it's not technically there at all times. It's basically there when we're pushing medicine through it. So there's a little bit different. When we're going through a ligament, we can't push the syringe in because there's resistance. But once we get into the epidural space, that resistance is gone and we can push the syringe in. The other way we could do this is called hanging drop. So essentially, same idea. We use a needle. We go in between these spinous processes, try to find the epidural space. This time, we're not using a syringe and we're not tapping on anything. Basically, we just put a little bit of saline at the end of the needle here. And essentially, when we get to the epidural space, this bubble of saline will get sucked through the needle because there's a negative pressure there. And it will, disappear from the end of the needle. And so that's called the hanging drop, because until we're in the epidural space, this is just kind of hanging here at the end. But then once it disappears, we know we're in the epidural space. All right, so after the epidural is placed, basically the medicine is going through a pump. So we hook it up to a pump that delivers medicine, either every hour or continuously. And then we also typically give the patients a button to press so that they can give themselves extra doses of medicine until the baby is born. Sometimes the baby is delivered right after placement or soon after placement. It just kind of depends on the labor course. But other times, the patient may need the epidural for many hours, up to a couple of days for the labor course to take place. A question I often get is, can an epidural be used for a cesarean section? And yes, it can, provided that it's been working well and we know that it's in the right spot. But we may need to, do some things to the pump. So we may need to increase the medicine. We may need to reposition the epidural catheter. Or, if it's not working at all, we may need to replace the catheter altogether. And so that pretty much sums up NEURAXIAL anesthesia. Obviously, there's different, ways that we can use it. Like I said, hip replacements, knee replacements, those sorts of things. We can also use NEURAXIAL anesthesia. But I want to move on to pain management. So chronic pain management is a subspecialty within the world of anesthesia. So basically, it's where anesthesiologists are trained just like any other anesthesiologist, but then they focus for a year after fellowship or after residency in a fellowship on chronic pain management. And so, they see patients with low back pain or neuropathic pain, which is basically a type of pain, from diabetes and other different conditions. They often do interventional procedures. So, they can do steroid injections for back pain or shoulder pain or knee pain or different joint pains. They can also do radiofrequency ablation. So they can go in and basically, I guess you could say, for a nerve causing pain. They can do those. And then they can also do nerve blocks if needed. They also do pharmacologic interventions. So opioids, can't be prescribed by these physicians, but also non-opioid medicines and other adjuvants, we call them. Obviously, in today's world, there's a lot of, problems with opioids and opioid abuse. So the shift has been more to non-opioids and these interventional procedures for pain instead of, just handing out a lot of opioids. So let's talk about a case real quick. So this is a 43-year-old female presenting with right foot and ankle pain for 2 months. You take a very thorough history. You find out that the patient dropped a heavy book on her foot before the pain started. She immediately went to the emergency room because she thought she broke a bone, but there were no broken bones on x-ray. So she was discharged on some ibuprofen and told her to ice and elevate her foot to keep the swelling down. So basically the patient went home, took the medicines, did what the doctors told her, and then the pain just got worse and her foot started to change color and got even more swollen recently. So this is the picture you see when she takes off her socks. And so, obviously this foot is red, swollen. We call it mottled in appearance. So basically you just see a bunch of blotchiness. You know, it's tender to touch. It's freezing cold when you touch it. And so basically what could possibly make a patient's foot look like this? So there's something called complex regional pain syndrome, or CRPS. So there's two types. One is where there's no clear cause. You know, patients can just wake up and their, you know, their hand, their foot, their finger, anything like that could just be swollen, red, just, you know, it can look like this patient's foot. And then there's another type where it's called causalgia. So basically there was an event that caused the CRPS to kick in. So in this case, you know, we kind of have an idea from the history that she dropped the book on her foot. So therefore we're thinking it may be more the type 2 CRPS. Some symptoms of this condition: excessive pain with even light touch to the affected extremity, you know, changes in color like the picture. You can also have changes in temperature. So just like I said, the foot was freezing cold. That can happen. It can also be blazing hot. It just depends. Every patient's a little bit different. There's swelling. So like the picture we saw, the right foot was much more swollen than the left. And then there's changes in skin texture. So, you know, often this means that the limb becomes shiny, thin, hairless, are common symptoms or things that can happen to the skin. So what do we do about it? So there's really no diagnosis for CRPS. It's a combination of physical exam and history of symptoms. You can use bone scans sometimes to identify areas of excessive bone resorption near the injury, but those aren't reliable all the time. So many cases resolve on their own. It just takes a lot of time. You can prescribe physical therapy, spinal cord stimulators, non-opioid medicines are, you know, typically preferred, but you can also prescribe opioids, so like fentanyl, other things like neuropathic pain meds, so gabapentin. You can put topicals on the area, so lidocaine or other topical medicines are options as well. But it can be very debilitating for patients. Obviously, this patient, you know, couldn't walk very well. She couldn't work, everything like that. So it's a very drastic effect on their daily life. All right, so I just want to touch on a little bit about the path to becoming an anesthesiologist as we wrap up. So basically, you know, you have to do 4 years of undergrad, 4 years of medical school. So in medical school, you typically study the same thing that all your classmates study. You may take a few different rotations in the hospital, you know, maybe more focused on the anesthesia, but for the most part, everything is very, you know, the same as your classmates. Then you move on to residency. So residency is split into the first year, which is called the internship year. You're rotating through different areas of the hospital, you know, medicine wards, ICU settings, surgery, everything like that. So it's really, you know, you learn how to become a physician, how to take care of patients, everything like that. And then your second through fourth year. So PGY just means postgraduate year, or the year after you graduated from medical school. So PGY 2 through 4 are the clinical anesthesia years. So you're basically rotating through different types of surgery to, you know, learn how to provide care for those patients. And then you can graduate and go on to be, you know, a great anesthesiologist, or you can go on to a fellowship, which is a 1 year commitment in, you know, a variety of fields. So cardiothoracic anesthesia, OB anesthesia, chronic pain management, so on and so forth. But like I said, a fellowship is not required by any means. You can still get a great job without a fellowship. It's more if you're interested in, you know, one of these subspecialties, you could definitely go on to study that more in depth. And then I just want to touch on certified registered nurse anesthetists, or CRNAs. So basically, these are folks that go through 4 years of nursing school, typically 1 or more years of critical care nursing, so in an ICU setting, and then they go to 2 or 3 years of CRNA school. So it depends a little bit on the school. If it's 2 years or 3 years, it really just depends on how much clinical training they have. The first year is typically classwork again, so you have to go over physiology, pharmacology, anatomy, those sorts of classes again. And then you go into the clinical setting. So you go in the hospital, you're providing care in the operating room under the direction of a CRNA or a anesthesiologist. And then the other question I always get about CRNAs is, are they a threat to the field of anesthesia? My answer is maybe. This debate, CRNAs versus anesthesiologists has been around since I was in pre-med, so over 10 years now. And some people at that point said, they're going to take over, anesthesiologists aren't going to have jobs. That hasn't happened yet. And so, I think the bigger thing is, we're going to develop a care team model. So there's places for anesthesiologists, there's places for CRNAs. And so we're going to work together to, take care of patients and provide them the best care possible. So one way to separate yourself is to do a fellowship as an anesthesiologist. So, there's less CRNAs that are, wanting to do pain management or cardiac anesthesia. So, it's a really good time to, do a fellowship and separate yourself from the CRNAs a bit. All right, so I just want to summarize real quick before we move into questions. So one of my attendings told me this one time: anesthesia is 97% chill and 3% complete chaos. So obviously we train for the 3% complete chaos. We're ready for it. But 97% of the time, everything goes very smoothly, and we don't have to do much, much extra than our normal. Some advantages of anesthesia as a field: you can carve out your niche that you enjoy. So if you're really interested in cardiac anesthesia, you can do that. If you're really interested in pain management, that's an option as well. Some advantages: you don't need a fellowship to practice. You can just do your residency, go on to do a great job, and you don't need a fellowship. And then you get to work with different types of physicians. You see different types of specialties, different types of patients, everything like that. So it's a very, there's a lot of variety in anesthesia. Some disadvantages: your hours can be long, exhausting, stressful at times. It's highly unpredictable. Some days you just don't know when you're going to get home, just because you're there until your operating room finishes, and if the surgeon's really slow, that could take forever. There's not much continuity of care and little to no recognition. So like I kind of mentioned before, the continuity of care can be a disadvantage, but for me, it was an advantage. And then, you're never going to be, or you're very rarely going to be recognized at, say, the supermarket for, your work. Typically, anesthesiologists are kind of behind the scenes. They put the patient to sleep, take care of them, but the surgeon is the one that's going to get all the recognition. So if you're looking for that type of recognition, anesthesia is not maybe the best field. And then lastly, the practice of anesthesia can be heavily determined by what your hospital, what the surgeons at your hospital are operating on. So if you're at a hospital that does a lot of orthopedics, obviously you're going to do way more orthopedic anesthesia. If your surgery is very heavily focused on cardiac, then you're going to be doing a lot more heart cardiac anesthesia. So, you don't typically have your own patients. You're kind of there as a service to the surgeon. So whatever types of patients the surgeons are bringing in, that's kind of, what you'll be taking care of. So some people may like that. Some people may think that that's not the way they want to practice medicine, and that's totally fine. So with that, I'd love to answer any questions you guys have. I have a lot of my contact info here. Once again, thank you for your attention, and thank you for having me. Let's get on to some questions.
Yeah, so thank you so much for your presentation. And the participants have sent in a few questions, so we're going to ask that. And while we're answering these together, if anybody has more questions, feel free to just drop them in the chat and we'll get to them.
Yeah, for sure. So our first question is, what is your opinion about the future of anesthesia and its scope?
Yeah, so I think anesthesia is still a strong field, and I think it's going to be a strong field for quite some time still. And I think, the scope is really, it may change a little bit for anesthesiologists. So, we're going to have to venture out more into the outside the operating room setting. So what's really big now is what's called non-operating room anesthesia, or NEURA for short. So basically, the GI lab where they're doing colonoscopies and other procedures that the GI doctors are doing, the cardiac cath lab. So, when patients get stents in their heart, I think that's going to be a exciting new field for anesthesiologists to, provide care for those patients. The ICU setting, there's intensive care units, needing anesthesiologists all the time. And so it's really going to be, kind of the outside the operating room. patients in general are having less, super invasive surgeries than they used to have. And so I think it's really going to change kind of how we practice. But in terms of field as a whole, it's still going strong. We're just going to have to adapt to, kind of these new settings and be willing to adapt to these new settings as well.
That makes sense. So the next question is, would you say that anesthesiologists have a better work-life balance than other specialties? And if so, what are some of the ways that you use your spare time and maintain a healthy balance between the two?
Yeah, so I think on the whole, we do have a good work-life balance. Like I said, we don't typically have our own patients. We just provide our services to the surgeons. And so therefore, once we leave the hospital, generally we don't have to, answer phone calls from anyone. We don't have to, come back very rarely. And so therefore it does lead to a little bit better work-life balance. And then, the hours can be long, you may be on call a lot, but you typically know when you're on call and you typically can prepare for it. The other thing is that anesthesia as a field is starting to move a little bit more towards shift style work, much like emergency room. And so, therefore, you're able to kind of just know when you're going to show up, know when you're going to leave. And so that's still a little bit early. There's still, quite a few jobs that need to switch to the shift style work, but I think that's going to be the future. Compared to other specialties, obviously surgeons are very busy. There's some better clinical specialties out there. So like dermatology, typically there's very few emergencies in dermatology. You typically have clinic hours. So, 8 to 5, 7 to 5, something like that. So anesthesia is not as predictable as that, but at the same time, I think with shift style, work a little bit more prominent, I think it'll, get better in that way. In terms of what I do outside the hospital, obviously, as a resident, we're still working quite a bit. But I still have time to take my dogs for walks, play sports, try to be physically active, enjoy Chicago, all those types of things. It's still a good, kind of work-life balance overall.
Yeah, for sure. So our next question is, what are some important skills or personality traits that you think an anesthesiologist needs to have?
Yeah, so that's a great question, actually. You got to be very diligent, very detail-oriented. You can't really let the details slip through the cracks. You need to, kind of keep an eye on everything. And there's a lot of things going on at times. And so, you got to be able to do those things, consistently. And then, you got to be, kind of task-oriented to some degree. So you got to know what to do now versus what to do next, and have kind of 3 steps ahead of you lined up. Those are the individuals that can do very well in anesthesia. You got to be kind of, I would say type B personalities do a little bit better in anesthesia. We're typically, a little bit more laid back until, the stress kicks in, and then we need to, do something very quickly. And so it's kind of the ability to turn those features on and off. So you kind of go from a type B to a type A personality in some situations. So if the patient's not doing well, obviously you got to, kind of have the intensity to make changes and everything like that. But for the most part, you'll find many anesthesiologists are pretty laid back, and they're, pretty, relaxed most of the time. And so, you kind of have to build that, barrier or ability to, look at things and realize that you don't need to be, switched on all the time. You can just kind of relax, and, as long as the patient's doing fine, we're a pretty relaxed bunch.
Okay, and so our next question is, what would you say is the hardest part of being an anesthesiologist?
So the hardest part I would probably say is, there's multiple things, to be honest. So, just the volume of information we need to know and comprehend and be able to deal with on a daily basis is quite a bit. Balancing everything that's happening in the operating room can be a challenge. You may have surgeons yelling at you for various reasons. And so, just being able to, be able to deal with all those different types of personalities can be a challenge. So, surgeons are historically known to not be the nicest people. So, being able to deal with that can be a challenge. Being able to deal with the fact that you're not bringing patients to the hospital. So you can be viewed as a little bit more of, a service. And so it's all up to the surgeons who bring the patients to the hospital and bring the money along with them. And so anesthesiologists are, sometimes looked at as, oh, you're just providing a service to us. So that can be a little challenging at times. But at the same time, without anesthesia, you can't really do surgery. So, when you bring up that argument, they realize, okay, I need you to do the anesthesia. So yeah, I would probably say those are the biggest things.
Yeah, that makes sense. Another question we had was, do you have any tips or advice for students looking to enter this specialty or medicine in general?
Yeah, so in terms of anesthesia, obviously try to get exposed as quickly as possible to the field. That can be a challenge. I know it's really hard, not just with the pandemic, even before the pandemic, it was very difficult to, try to get in an operating room to see what anesthesiologists actually do. But if you can, that's, probably the best experience you can get. Hopefully we can get back to some sort of shadowing in the next, 6 months or so. But at the same time, I don't know when that's going to happen, to be honest. So in terms of medicine in general, just start thinking ahead. The application process is a very tedious process. It takes a lot of time, a lot of effort. So start planning ahead and, do your research in terms of what you need to do to apply to medical school. And so there's, different essays you have to write. Obviously there's an application process. You have to get letters of recommendation. So just kind of, start lining those things up ahead of time if you're truly interested and you want to become a physician. Because it's really never too early to start on your application. And so, just kind of, a quick Google search will show you, basically everything you need to know about how to apply. And so, you can always do that.
Okay, and so now this is our last question. Someone was wondering, does your throat hurt or get sore after you take the intubator out?
Yeah, so after you take the breathing tube out, you can definitely have a sore throat. So one of the side effects we talk about when we talk to the patients about anesthesia is the fact that you may have a sore throat after surgery. That's pretty common, actually. It feels like that scratchy throat feeling right before you get a cold, but it goes away on its own. You could have ice chips, cough drops, or whatever kind of helps with this sore throat. Hot tea, but it will go away on its own.
Mm-hmm. Okay, so that's all for our questions today. Thank you so much, Dr. David, for your presentation and answering all the questions that our participants had. Would you like to give any final comments?
No, thanks for listening, and feel free to reach out if you guys have any questions about anesthesia or medical school admissions in general. I'd be happy to help.
Thank you so much.
Yep, thank you.
So just for our participants, make sure to fill out the form that will be posted to our Linktree tonight in order to get your volunteer hours. As usual, if you get over 50% on the quiz, then we will email you your certificate with your volunteer hours by Tuesday. If anybody has any more questions about the volunteer hours process, you can drop them in the chat. And if not, thank you to everybody for attending this seminar. And remember to follow us on Instagram to keep a lookout for our next seminars. Thank you.